All right, so let's continue with, now we have a wound and it's not healing. And so there are complications to our wounds. And when we have failure to control the bacterial growth, we're going to get an infection. I know this isn't a very good picture, but you can see what color is that drainage. It's yellow, okay? It's purulent drainage. It's like pussy looking, isn't it? That's infection. And what are we going to get from an infection? What's our patient going to get? A fever, potentially, right? A fever. There's going to be swelling and redness. Obviously, it's not approximated. It's not closed. It's open. We can see the infection. There is going to be, when you look at their lab work, their white blood cell count's going to be up. That can tell you that there's an infection, right? So this is one of the complications, is infection, obviously contaminated. Another complication is hemorrhage. So if we get a wound and it begins to bleed, but then excessive bleeding and hemorrhages, we get, what do we have to do for that? We got to stop the bleeding, and we stop the bleeding by pressure. So you have to have some kind of pressure to stop the bleeding, or pack it until they can maybe get them to surgery, find out they know what's caused it, they have to go in there and fix it. All right, that could be the potential. When you lose a lot of blood, what about fluid? Yeah, we need fluid, don't we? So you have to replace the fluid with, more than likely they're gonna get blood. And we have to replace that. Probably have an IV running as well. But you have to put pressure, pack it, and give fluids, and then if they have to go to surgery, they may have to go to surgery, okay? Obviously, we wanna have gloves on if that happens. We walk in, our patient's bleeding. When you grab something, that's why it's always a good idea to keep an extra pair of gloves in your scrubs all the time. You run into an emergency in the hallway, in the room, you don't have to run and go get gloves. You got them right there. Put them on, don't touch anything, cover that up, put pressure on it. Something that can happen though from hemorrhaging is hematomas. Or you can have a hematoma, which means that there is a localized mass of blood, which then is going to cause a clot. So it's called a hematoma. All right, wound complication, dehiscence and evisceration. So we said that dehiscence was, okay, our wound opens up, so it's exposed, and it could be that only part of the wound that happens, or the whole entire wound. It could just be the bottom that opened up. That's still dehiscence. When those layers open up, because there's stress on the wound, which is why somebody, when they have surgery and we want them to cough and deep breathe, we splint that wound if it's in the abdomen, because it's gonna put stress on the wound. So by pushing it, then they'll push out here and not here where the wound is, okay? If it's not in this area, you don't have to splint. But if it's an abdominal wound, chest, you gotta splint. It's gonna hurt too, plus that helps to grab something and hold on, all right? But when that happens, if there's stress on the wound, it can pop. That's dehiscence. This is a picture of evisceration. I don't know if you can see it or not. Way at the top though, there's a tube coming out. It's coming out of the patient's mouth. That's their head. And this right here is abdominal. That's evisceration. So if they had a wound and it was closed, it came apart, you're gonna see organs. There's a bunch. And what happens is you walk in and see that, or you see it in the bathroom because the patient went to the bathroom and it popped and it eviscerated. You gotta get your gloves on. You gotta put sterile on that, get all the gauze we can get, cover it up, and they have to go to surgery, obviously, right? but we don't want the patient touching it. We want to cover it as soon as possible with sterile, probably sterile saline too, so it doesn't stick. Get that wet, cover it up, get them to surgery. And if we cover it up, the organisms from the air, anybody coughing, anything is not going to get into our wound. That's what we have to do.
Have you ever seen that?
I've never seen that, no. It did happen to my uncle, but I have never seen it. My uncle had surgery and he went to the bathroom. Everything fell out. And he was a construction guy, so it was in like a porta potty. He should not have been back to work. But Tara says she has seen it before.
Think about some self-injurious behavior people, your cutters and stuff like that. People, we had a guy in prison, corrections is my background for anybody that doesn't know. Had a guy that decided to just slice himself open, everything spilled out.
Yeah.
Had a guy take his balls out too.
What's that?
Had a guy take his balls out too.
Take his balls out?
Yeah,
Yeah.
he sliced his scrotum and,
Was rolling him in his hand, I think.
yes.
Okay, didn't see that going that way. So, who when we would possibly see this is at risk? Obviously the prison population. But what about in the hospitals? Who's gonna be at risk for dehiscence and evisceration? Surgical patients. Elderly, maybe because they can't follow direction to splint, and maybe if they get up and start moving around, obese patients, right? They're gonna be at risk, okay? Surgical patients, people who smoke because of the damage that's being done to circulation, right? If you have an infected wound, it's more likely to come apart. Excessive coughing or someone who's vomiting continually, that can open wounds, okay? And straining. So that's why we want to make sure that people have stool softeners post-op. We don't want them, we put them on all this pain medication and the side effect of that is constipation. So we got to make sure they're getting enough fluids and mobile and all of these things so they don't get constipated, but we definitely don't want them to go into the bathroom and strain, because that will pop things.
I just have a curious question. So if it falls on the floor and you cover it up, how do you lift
You
it
want
up?
to put it back to the patient as
Okay.
best you can, and then put the saline, the gauze, and cover it up, and they go to surgery.
Okay.
Yeah, you're not gonna disinfect, because even if it is on the floor, you're not gonna disinfect or anything like that, because you just are gonna give it back to them, cover it up, and they're gonna go to surgery.
And you would put the saline inside after you put it in, or?
Yeah, you can put saline in, put the gauze in, and put saline gauze in
Okay.
over top of it, because those are sterile, they come in a sterile package.
Okay, gotcha.
Okay. Where? Another question? Who had a question? Uh-huh.
This might be dumb, but like if someone has
Has a
like a hernia,
hernia? Yeah.
could they like have that happen? Because isn't that like what if they get a cut right there or something like that?
Well, it wouldn't come out necessarily. I mean, it could come out where there already is a hole, I suppose. But yeah, it would have to be cut for the hernia to be
Because our
exposed.
patient on Friday, she just had a GI bleed and then she had surgery. Well, she had this like huge hernia right here,
Mhm.
and then that picture as well.
Yeah. This would probably not happen to a hernia patient. At least I've never heard that. Yeah.
So, a female with a hysterectomy, do they put like a sleeve underneath to like keep everything in?
If they have a hysterectomy, they've taken it out.
Yeah, so do they have to put, cause I worked in an OB office and there was a patient that came in with excessive bleeding and they ended up, she'd had, I think a total hysterectomy, they had put a sleeve to like keep everything inside, like all her organs.
Mm.
And that sleeve had come apart and they were worried about all her organs coming out.
Yeah. So that would be evisceration, yes. Yeah. Yeah, they'll do different things to try to keep things in, and that's one of them. Yeah. But if this happened, we're talking about wound healing, so if we have a patient that this would happen to, this is what we would do immediately at the hospital, okay? All right, another complication of a wound is a fistula, which is if you're taking two things that don't necessarily go together, like in this picture it's a vein and an artery, and you've put them together and you've shunted it, put a fistula. If you do that, that's what it's called. So you put two things that don't necessarily go together, or something that's, you're making a passage from internal to external. You make a passage, that could be a fistula, okay? What happens though, and a fistula here you might see with patients who have dialysis. You know, they have to go in and have dialysis, so their body is not filtering the blood properly, so they go and they're hooked to a machine. So they'll put a shunt in, and this is what it looks like. It's underneath the skin, but that's what it looks like. They put this together to shunt the fluid where they want it to go. All right? So obviously you're gonna have complications because you've created an area, you know, you opened the wound, it would be intentional. You opened it, and so then we have to have healing. So we would always want to be checking that area to make sure that it's healing. Skin breakdown would be one for that. All right, if you have a pressure injury now, this is not something where your skin is cut. This is, you're putting pressure, and we talked about it with our mannequin here. A pressure ulcer. You can have external, okay, localized damage over a bony prominence. So all of those, the shoulder blades there, the elbows, okay, the bottom area, our knees, our heels, all of those are bony prominences where we can see pressure injury or a pressure ulcer. Your book refers to it more as a pressure injury. I'm just used to pressure ulcer because I'm old and that's the way I learned it, okay? So I think Lori tomorrow will say the same thing, but your book refers to it as pressure injury. It's the same thing, all right? Well, you lost that, didn't we? Okay, so it might occur more in the elderly because we've already talked about what happens in the elderly. Also, people who have spinal issues, brain issues, because they can't follow directions possibly. There might be some intellectual disability there. Neuromuscular disorders, people who have ALS, MD, muscular dystrophy, all of those things, they are at big risk to have a complication of pressure injury. And they cannot move themselves. I mean, if you've got an ALS patient who's paralyzed from the neck down, they're not feeling that their bottom hurts. They don't know if it's broke down. They can't tell you, which is why if you care for someone like that or see some, you really have to do a good assessment to make sure there's no skin breakdown. We have to teach the family that for someone in the home. You have to look at their bottom and you have to turn them because they will not feel it. And then we'll get a pressure ulcer, not just a pressure injury. All right? Some external things though are inflammation, an ulcer, if you have necrotic tissue, ischemia, which is deficiency of the blood in an area, hypoxia, which is inadequate oxygen. So if those things happen, when you put pressure on it, we don't get oxygen, we don't get circulation, we're gonna get a pressure injury when that happens. The other is, we talked about it in one of the questions, friction and shearing. So we do not want to just grab that, which I don't even think this patient has a Chucks or drawstring, but you don't wanna grab it and just pull up, and then they just slide on the sheet. Okay, we need to move them up and then move them back and turn them. Because if you cause friction, that will cause skin breakdown, or shearing with the sheets, that will cause skin breakdown, which you guys should have learned in your STNA courses, right? Say yes, Mrs. Crum. Okay, well, so we have a risk assessment. We've talked about the skin already, but there are some different scales that you're gonna see out there when you guys are doing clinical, especially when we were able to before COVID, and we were able to go into the nursing homes. You would have used the Braden scale a lot, because they have to assess the patients often for skin breakdown, and one of the scales that they use is the Braden scale, but there's a couple more here, the Norton scale and the water flow scale, which you can look up in your book. But what happens with those scales are you assess your patient, and whatever's happening with them, you circle that and it'll have a number attached to it. Then you add up the numbers, and if it's between this and this, then they're at more risk. If it's between this and this, they're at high risk. Okay, so that gives us an idea as to, I probably maybe want to check my patient more than every 2 hours if they're at high risk, all right? So that's what happens with those scales. You're looking at, when you look at those, you're looking at sensory, you're assessing, you know, can they feel when you touch that? You're looking for mobility. You know, are they able to get up? Do they have, well, that's fall risk, I'm sorry, not wound assessment. Moisture, you know, are they incontinent? It'll ask you that. And how often are they incontinent? What is their activity? What's their nutrition like? Are they only eating 20% of their diet or every meal? Is that it? So that's poor nutrition. And is there any breakdown already? So those are the things you're mostly going to look at on these scales. So what is your part as a nurse if a patient scores high in one of these areas? Do you have any responsibility? Okay, I'm seeing yes. What is the responsibility? Okay, notify the healthcare provider. What else? Implement measures right away. So like if you see it on their coccyx, get them off of it, right? Okay, if you see that they're incontinent, don't go call the aide, maybe to help you, but don't say, Mrs. Jones in 217 needs changed. Change her. Don't forget what you learned in STNA. That's part of a nurse's job too. It's not, well, I graduated from that, so now I get to pass the meds and tell everybody else what to do. No, especially because when you change that, you get to see. And you don't have to go in there and then take it all down and check them again. You get to check them right then. So if there's incontinence, you got to take care of it right away. Call the healthcare provider if they need something, a barrier cream or something, but you tell them that. And you document what you saw. It's abnormal, so we document that in the notes, not just a little checkbox. Say what you saw, how big is it, all of those things. All right, prevention. So some things that we can use to not have the skin breakdown. If there's dryness, our patients, we can use lotion. When you guys learned that in your STNA course, when we put lotion on, how do we put it on? Okay, if I'm gonna put lotion on this patient's leg, there's dry skin, I'm gonna put the lotion on and then I'm gonna do this, right? Why? Why am I doing that? Circulation, but why am I going in that direction instead of this direction?
The way the skin goes.
What?
The way the skin goes.
The way the skin
So
goes.
you're not creating friction when you rub down.
No friction. There's another reason why I do that. Blood flow. I'm trying to get that back to the heart, right? Isn't it when you do back rub, you start it here and you go up and out? like that, okay? Because you're pushing the blood flow towards the heart. There's a reason why you had to do it a certain way. You might have got frustrated, and you might get frustrated with nursing skills, but there's always a reason why we do what we do. And it's not like, well, that's stupid, that takes too much time. Well, and then your patient gets a DVT, and they can't walk, when you could have prevented it. That's our job as nurses, prevention, okay? Avoid friction, avoid hot water. We want it tepid, right? We don't want it hot, because that could burn the skin, and then we've got breakdown. What else? If they need any kind of a support, like when they get up, they have a walker in the room. Why aren't we making them use it? Use the things that you have to prevent falls, to prevent skin breakdown. Okay? Okay. All right, risk for injury development. So a lot of these things are going together. They should be making sense. You know, the risks are the risks. The development, the injury is the same. So if we have risk for injury development, it possibly could be because our patient is immobile. And sometimes, even though the order says turn Q2, but you did your assessment and you need to turn them, it's okay if you turn them Q1. You don't want to go past 2 hours, but you can go do it more often. There's nothing wrong with that, right? If they're immobile, we want to get them mobile as much. They may not be able to get up and walk. Maybe they're bed fast, but we can turn them. We can, get them to one side or the other. You can put their legs up, put them down. There's all different things you can do, and these beds are wonderful. A lot of the beds have the airflow in there, because that's supposed to help with, pressure injury, potential pressure injury. Nutrition and hydration, we've talked about that. Upping the calories, upping the protein, making sure they have electrolytes, they're not dehydrated. How do we check for dehydration? Skin turgor, okay, where? Mostly the elderly here, okay, because if you do it here, I'm almost 60, I don't bounce back as good as I used to, okay? So that may not be a good indicator. Look, it's still staying there. So you might want to do up here to see really, okay? What else? Circulation. Capillary refill, that's right. Okay, capillary refill. So when you're checking these and they're not within the normal range, don't just document it. Is there something you can do about it? I mean, if they're dehydrated and they're not on a certain fluid schedule, give them some more fluids. Go in every hour when you go check on them and say, have you had a drink, Mrs. Jones? Here, take some fluid for me. Right? Or set up a schedule, like depending on who you're working with, adolescents, children, like kids. I want you to drink this amount every time a commercial comes on your television program, something to get them to drink and to do what they should for nutrition. And what vitamins are they getting? Do they need a supplement? They might. All right, what else? Moisture. Well, we can do something about that. I just talked about it. Stool incontinence. I've seen some or heard of some really bad situations, leaving people in stool is just as bad as leaving them in urine. And because it will dry, and then the patients it'll itch, or they know something's there, then they get it underneath their fingernails. And then when you go to get it off, that area is gonna be red because that stool has stuck to their bottom or wherever. And when you pull that off, then now you've got a first stage wound. So we wanna clean patients up. Perspiration, if they perspire a lot. Don't just chalk it up to, well, he's the 300-pound man, he's gonna perspire. Well, yeah, but I gotta change this. I need to change this. His head is wet. on the back, it's wet. Do I need to change his gown more often? Okay, do I need to change the sheets? Okay, he perspires. Don't just document it and be done with it. Do something about it. And then what's their mental status? Are they confused? I mean, that's part of your assessment too, right? So are they alert and oriented? If they're not alert and oriented, you can't tell them to do something and then leave. They're not probably gonna do it. So if they're confused, is there somebody there with them? You could speak to that significant other or that person. Is their mental status, are they just apathetic? You know, I don't feel good today, I don't wanna do anything. You know, they just, if they don't want to, that is not the time to say, is it okay with you if I do your bath now? No, you don't ask. You're not being impolite. It's, we're gonna do this now. If you get tired during it, you let me know. But it's not, are we gonna do it or aren't we gonna do it? We're gonna do it, right? Okay, so if they're comatose, we have a patient that's comatose. Do we do anything different?
No.
You're gonna assess the skin, tell them what you're doing. Talk to them just like they're there with you, and they probably can hear you. They say that hearing is the last sensation to go. So you talk to them and tell them, we're gonna get a bath now, I'm gonna wash your bottom, and then we're gonna put some lotion on, and then we're gonna move you to your right side or your left side. And then we'll be back to change you again. You talk to them, but they're more likely to have, because they're not moving more than likely. So you gotta assess and check those pressure areas. And obviously their age, the older they are, the more at risk they are, depending on all the other factors that play a part of that. Do they have comorbidities? Do they eat well? You know, do they exercise? So you could have one 80-year-old that looks totally different than another 80-year-old. So you have to take that into account. Some psychological effects of having a wound is pain. And pain is what the patient says it is, correct? So we don't make judgments. We're kind of not allowed to really, but can they ambulate? You have to get them to cough and deep breathe. It's going to hurt. And you tell them, but this is why we're gonna splint it. This is why we're gonna do such and such. What?
Did somebody lose a phone?
Somebody lose a phone?
To the bathroom. Okay.
Give it to Darlene.
Not
Nick.
there.
Oh, she's not there?
No.
Go down the hall and see if one of the other instructors are there.
Okay.
Yeah. Okay, so pain. You're gonna have pain potentially when you change the dressing. You know, when you remove the stitches. Yep, there's some burning. You just need to tell them those things. And you'll learn those as you get farther along in your career as to what those are. Or if you've had them yourself, you can tell them. You know, it's not really pain, it's more like when you take the stitches out, it burns and there's a little tugging, but you don't have any nerves there, they cut it. So there's not like a whole lot of pain, but people get anxious too, like there's gonna be so much pain. So sometimes we have to deal with the anxiety more than the actual pain. So if you can give them something, that might help. So anxiety too, sometimes they can smell their wound, and sometimes they can see it when you change the dressing. And they get really anxious because if they haven't been educated as you are, they don't know that that's good. You know, once they know, people know you're a nurse, and the neighborhood will come around. Hey, I got this, could you check my daughter's, you know, whatever. You're a nurse now, so you're supposed to know it all. We don't know it all, but we do know what it should look like. So is it infected? Is it not? And patients get nervous, you know, when it's swollen and it's red, and you know it doesn't look good to them. You have to assure them that it is, because that anxiety plays a part of it. And make sure that you provide privacy. When you're changing wounds, provide privacy. shut the door, pull the curtain for the patient, all right? All right, psychological ADLs. They can or will negatively impact the patient's life if they can't do their ADLs themselves. That can be really hard for somebody else to like brush their teeth or something, you know, that's hard. So if they have a wound that they can't do anything about really, you just reassure them that they are following their diet, they're getting their nutrition, you know, they're having bowel movements, whatever it is, just assure them so that we don't get to a point where it negatively impacts their care, because we don't want that to happen. We want them to, once they can do it, have them do it, make them do it. Don't do it for them. You know, you'll get those significant others or family members in the room that'll be like, oh, I'll feed her, I'll take care of her. She can feed herself. Okay, and when they go home, she needs to feed herself, okay, or whatever it is, because that's just enabling behaviors that's not good, and you know that there's going to be skin breakdown and stuff if they don't do things for themselves and move. And then body image. So suppose you had a mastectomy. Now my body image psychologically, I don't want to look at that. You'll hear different females and possibly males who've had breast cancer and had to have a breast removed. They don't want to look at it right away, or their significant other doesn't want to look at it. So we have to deal with those kind of things, psychological, because it can affect intercourse, it can affect a marriage, it can affect a lot of different things, just my body image. And you know, we'll get to it when we talk about peds, but like anorexia, bulimia, psychological things that matter, their body image is important. So that can be an effect. So here's more of what you'll learn usually, or Lori has talked ahead of me, and then I just kind of go back over this. But tomorrow you'll learn the stages, and I know it's blurry, but I basically wanted you to look at the pictures and not necessarily look at skin, because you need to be able to see the little red triangles are like above the skin. Like the skin's been cut, it is swollen, inflamed, but you have a cut. And how deep does that cut go? Lori will talk about the different layers that you'll hit, and it'll be a stage 1, a stage 2, stage 3. We talked about it at the beginning. A stage 1 is blanchable, which means I can touch it, it's red, but it comes back. And the skin isn't broken. That's a stage 1. And then as you go down the layers, when you get to stage 4, you can see bone and muscle, okay? And but in between there, you have stage 2 and stage 3. So she will go over that a little bit more tomorrow, and she'll talk about how do you stage it. Because once you stage a wound, even though it heals, it always was a stage 2 or stage 4 or whatever. So you always in your documentation will say a stage 4, even though it looks now like a stage 2. But you're always going to, you guys will be ahead of that. Don't tell her I told you. And you'll be able to tell her tomorrow when she asks that question. So you always keep it as a stage, whatever you, the nurse initially called it. All right, so here's a couple different ones, and I did that on purpose. So so this is A up here. When you look at that, can you tell? No, you can't. Okay. Is the light bulb going out or what? I'm not paying attention to it. Okay, so a stage A is a stage 3. Okay, you can see, can you see the purulent drainage? It looks infected to me, doesn't it? But it's also, it's how deep it goes, how deep it goes. And you can see that there's some looks like potential tunneling, there, you might not be able to see it. There's a couple red holes there. So you have to stick like a Q-tip down in there and see how far it goes in, cause that's how deep your wound is. So stage 3 is gonna go past the top layer, second layer, close to getting down into the 3rd layer, not subcutaneous yet. Okay, then if we go over to B, that's a wound vac. You may see people with those now, and that in there is charcoal. It's, charcoal will absorb the moisture, and then, so it'll absorb it, and then it'll shoot it out the tube, suction it out, and it'll gather in some kind of a container. So if we've got a lot of drainage, the wound vacs work really well, so that then they can eventually get all that drainage out and close it up and then have it heal. It's open right now because it's got the wound vac in there. And some people have more than one, because depending on where they are, they might have to have more than one. C is stage 2. Can you see how red it is though and meaty? That's pretty good. It's starting to maybe have a little infection on the outside, but it's not very deep. That's not a very good picture, but it's not very deep. It's past the first layer of skin down in there, but that's as far as it went. It's nice beefy red, which is what we want to see. And then D is a stage 1. Okay, so if I put my finger on there, it would blanch. It didn't go below the top layer of the skin, even though it does look like over there might have been it's scarring over there. That's a stage 1. Okay. When you have a wound, though, you have to measure the farthest points of the wound. So when you have wounds like this that you don't have a definite like up and down. So you got to find the farthest part across and then up and down. And that's what, so you say it's like a 3 centimeter by 5 centimeter. Okay, so you have to measure that. You also have to measure the depth. And most of the time you do use a Q-tip. You stick that in, and then when you have gloves on, you mark where it was, and then you put that to your tape measure and say that it's 3 centimeters deep. If there's tunneling, then you have to describe that, and if you just say that, which means it goes deep, but it's like just in one spot. So it's starting to tunnel. So we put that in our documentation. We also put in if there's any drainage, and we say what it is. Is it a lot? Is it a moderate amount? Is it a mild amount? How much was there? What did it look like? Then you're gonna start using, we'll do it here in a minute, but serosanguinous, purulent, all those different descriptions. And then does it have an odor? You gotta say if it has an odor or not. You're gonna say if the edges are approximated or they're not approximated. If there's stitches, how many stitches are there? Count them. Okay? All right. So, and this is where I was going, wound drainage. So when you assess a wound, if you have drainage, it's gonna fall in one of these categories. If you have serous drainage, that's clear and watery. This picture is not of clear and watery. But like I have dry eye. But sometimes I'll just get with them cutting the fields down, allergies, and my eyes will start to, drain. It's clear, there's no infection, so that would be serous drainage, okay? My eyes are not supposed to just drip all the time, unless you cry all the time. But, so that would be serous. Yeah, you guys might have a lot of serous drainage, right? In nursing school. Okay, and sanguinous. So make sure you know how to spell these too, so that you document properly. So sanguinous, it looks like blood. And why I say it looks like blood is because you're going to describe it not as blood necessarily, but red drainage. It's red drainage, which it is blood. So that's sanguinous. And then we have serosanguinous. So that's the mixture of the two. You get the clear and the watery with the blood. So it's kind of pinkish colored then, because you got blood but water, and so it fades out that darker red color. So there's serum and there's red blood cells in serosanguinous drainage. You get both of those. And then purulent, which is what this picture is. Purulent. It is thick. It usually has an odor to it. Okay, it can be various colors, but you're going to be more in your yellows and greens because it's infected. So if you have that, you better get to the doctor. Yes?
So, my medical patient last week was there awaiting a sacral debridement. He had a stage 4 sacral ulcer.
Okay.
So he had all of those. Like he had.
Somewhere or
Like
in
all from the same thing.
the same spot?
It was leaking everything out. Like we had to change the glue, like the bandage and the sheets and the incontinence pads and everything every couple hours. It was
Draining so much, and they didn't have a drain to suction or anything? Wow. Was the wound open? It was just the sacrum, so they left it open?
Yeah.
Yeah.
Cause he was there, cause he originally had an infection, cause he was bilateral above the knee amputated
Okay.
and had a bone infection. So they took him more off the legs and then he also had that, so
Wow.
he was the.
That one would be difficult to
Yeah.
document.
Copious drainage.
Yeah, you just say copious drainage.
And then if the wound bed is different colors, we document it in like percentage. What we see.
Yeah. So you will get familiar with a lot of that, but like if you have a patient like that, I would go and look at the nurse's documentation to see how they documented that. Because that'll give you an idea. They might not always be the most correct, but you can at least see how did they measure it? Is it right? And if you can follow up to actually measure it, it would be fun, but you don't always get that chance with the patient. Yeah. Yeah, there's a good to see if there's a change, that's right. So you're looking for that. You know, has the drainage slowed down? Are you only having to change it now every 2 hours or 3 hours instead of every hour, whatever? That would have been an interesting case. I've seen that. I used to be a wound nurse in the nursing home, and I mean I've seen it all the way down to the bone. You can see the coccyx, and it's not fun. And when they smell, it's difficult to hold your breath because it's bad. Okay, so this is something from your book. I don't see this necessarily like they document this, but this is a way that you can classify your wounds by red, yellow, or black. So if it's red, like beefy red, like I was saying, that's good because we have circulation. We want that color, we want red, and it means that there's normal granulation taking place and it needs to be protected. So you'll learn tomorrow, like what do you do for that? Yellow though, if you look at yellow, just like that drainage we saw from the eye, it was yellow. So it's if you use this classification, the yellow is that slough, that exudate that's coming off, the drainage. And when that happens, we need to irrigate. We need to get that fluid off of our patient when it gets to yellow. If it gets to black, we know that that's necrotic. We know that that's eschar. All right, so that has to be debrided. So this is a classification you can use. I don't necessarily see it, but you might see it on some documentations at different hospitals that you have to classify it that way. But it's pretty easy to understand if you understand wounds. So I kind of already went over this, but when you inspect the wound, make sure that you actually look at it. And obviously you take a few, you smell anything, okay? Is there an odor? If there's not an odor, that might be a good thing, okay? Where is it located? Okay, so you document based on what the approximation from a bony prominence, from a bone. So you should use that as your landmark, a bone, as to where your wound is, or if it's an abdominal wound, okay? Is it right or left, lower, upper, those kind of things when you document. And you are gonna document in centimeters, not inches, centimeters, or potentially millimeters. And is it approximated? We talked about that. Drainage, know those things we talked about, the 4 different kinds. And then if they have sutures or staples, or they have a drain, sometimes they'll put a drain in and they'll stitch with just one stitch there to keep the drain in, and it's flowing, and you just change the dressing. And then you always look at the dressing. Can you smell anything? What does it look like? How much is there before you get rid of it, so that you can document that. Then you look at the wound, do all those things we talked about. Does it smell? What's the approximation? What's the size? Okay, and the depth, and then and if there's any drainage, and then redo your wound, whatever the dressing is for that. If you see a drain, sutures, staples, obviously if you're not taking them out, they have to stay. But I would count them, because that should be in your documentation, because it should be the same count as the surgeon put in. If it's not, did we lose one? So we need to know that. If we don't document it, people don't know that, all right? And then assess around the drains. Because if they have a drain coming out, their body is open, but the skin is broken. So what does that skin look like? If they have a chest tube, or they have a drainage, a JP, a hemovac, which we talk more as we advance. So we do that wound assessment. And then, why do we put dressings on it? Okay, you're gonna learn more tomorrow about what dressings, but why do we do it? What's the purpose of wound dressings? Obviously to keep bacteria out, right? Okay, to try to keep the wound so that it will heal and it won't get more any kind of infection in it. We want our wounds dressings to absorb any kind of drainage, whether it's a vacuum, or it's just the dressings doing that. Because there's different kind of dressings that'll be wet and dry. And I might need to pack a wound, like if it's tunneling. I gotta get something down in there to pull out the drainage so that we don't get an infection. So we're gonna do that. We're gonna try to maintain the moisture balance, because the wound does need some moisture, but we don't want it to have so much moisture that we cover it up with a dressing and it's in a dark, moist place, which we don't want, because that causes infection. So there are some dressings that will pull the drainage out. There's other dressings like a coccyx. If you're at a stage 2, probably not a stage 3, but a stage 2, and they put something on there called a Duoderm, or what is it now they use in Mepilex? Yeah, you're gonna see that a lot. It's not to be removed. It's supposed to stay on there to have it not be infected, but also to try to get granulation and regrow tissue. So if you put one of those on, you don't take it off for like a week. I don't know what Mepilex, is that a week? Okay. Okay, 5 to 7 days. And unless it's just really, like if it's on the coccyx area and it's soiled because they're having diarrhea, or you can't have a dirty dressing stay on there like that, okay? But otherwise, we want to keep it on there because we want our wounds to stay moist, but we don't want to cause infection. So what's the purpose of wound? I lost something here. Okay, it's just an additional one, I'm sorry. Protect the skin, that's around the dressing. So we always look at the wound, but we want to look at around it too. Does that have nice granulation? Is it approximated? That's where we're looking around the wound to see how that skin is doing. And that's what a dressing can do, is to try to get that to regrow. Sometimes they have to debride. So they'll go in there, they're just getting so much drainage, they'll go in and they will really irrigate it with saline, or they'll pull things out to try to just get that infection out of there if it's bad and it needs debrided, and then kind of like start over again. And hopefully we get the infection out of there. Stimulate or optimize the healing response. How do we stimulate that? How do we stimulate healing? Anybody got an idea? Sometimes those dressings will have something in them, like seaweed. If you're using it to get the exudate out, they have like a seaweed dressing, and they put it in there and it pulls it out, okay? So that will stimulate growth by just pulling away the bad stuff so that the tissue can grow, all right? So it stimulates in that way. It could be a dressing. It could be, well, you're gonna stimulate growth around it when you pull the tape off and you've got skin around it that's good and healthy. That's gonna try to help that wound as well heal. Consider the ease of use and cost effectiveness. So we don't want to just change dressings because, hey, we get to do a skill and we want to change the dressing. I know we want to do those things, but we got to be cost effective too, where, especially if you're doing a sterile technique, if you're breaking sterility, you have to keep changing your gloves and changing your gloves, or you have to get another, like if you break sterility putting a catheter in, you have to get another, that gets charged to the patient. So that's why you want to do your skills well and be cost effective as much as possible. We don't want the patient to get any kind of an infection, so I'm gonna change the catheter. But that cost is going to your patient. So we want to be cost effective when you're using all the supplies, because when you take those supplies, they're put on your patient's record and they have to pay for it. So we don't want to just get a whole bunch of supplies, and once you take them to the room, you can't take them out and give them to somebody else. That doesn't work at the hospital. So either the patient has to take it home, who knows if they'll use it, but it got charged to them, and we put too much in the room, and we shouldn't have done that. So you want to be cost effective as much as possible. All right, so we have a critical thinking last thing we're going to do here. So during clinical, you have been assigned to care for a middle-aged woman who's had a breast removed because of cancer. Okay. The patient, Mrs. Nola, is an attractive, usually cheerful woman who's eager to get better and return home. However, while changing her dressing, she tells you, "I just can't stand to look at myself." Her husband left the room during the dressing change after telling you, "It makes me sick to see what happened to my wife." Mrs. Nola is to be discharged to her home the next day, and she needs to learn how to provide self-care for her wound. What do you do?
Home health nurse.
Anybody got an idea? What's that?
Home health nurse.
A home health nurse, which can be follow-up. What was it?
Support groups.
For her and her husband, right?
Educate,
And what are we going to educate him about?
normal processes of what is taking place with the body.
Okay, but she tells you, "I can't stand to look at myself." So how's she going to do self-care if she won't even look at her wound?
I would ask for permission if you know somebody that's been through there, see if they can come talk to her that
Okay.
day.
Okay, there might be somebody at the hospital that could do that, that could talk to her. Okay. I mean, education's great and we should do it, but if our patient isn't responsive to it, we're not doing the best for them. Okay, so first of all, I would deal with the patient, and then I would try to have a conversation with the husband, right? And try to pull them together. So, she's gonna be going home tomorrow. Yeah, so it's not that we necessarily waited too long, it's just the patient might not have been ready. Okay, so if she's not ready, we definitely need home health. We need somebody to go in and check and make sure she's changing her dressings and that she's doing the exercises or the things that she needs to do because of the surgery that took place. Okay, even a social worker to go in and see how things are going between her and her husband. Okay, and are they attending groups and just finding out, doing an assessment. This is a tough one because this is going to happen a lot in your careers because patients do not stay in the hospital very long. For us to try, for them to work through some of these things, it doesn't happen. And so you got to be able to do the best you can with the time that you have. So prioritize what's the most important thing my patient needs to learn. It might just be one thing before they leave. And then I'm documenting that and having a conversation with home health or whoever, because they need to know the situation before they walk in there. And, you know, the husband isn't part of it. And we may not be able to affect that in the hospital. Be great if we could, but I don't know, she's going home tomorrow. So any other ideas about this patient? She's got a wound. We need to do education on that. And maybe it's written. Maybe we don't get to talk through all of the things, which is really important if you do a little bit at a time when you're changing dressings, because you don't want to get to that last day and like have to vomit on the patient all the information and education that they need. Take time when you're doing your dressing changes to explain to the patient, you know, when you go home, you'll have to change this dressing. Or when you go home, you won't have the stitches anymore, and this is what you're gonna need to do. But then also following up with some kind of a brochure or documentation or something, so in case they get home and they go, I forget what she said about, well, I'm running a fever. Okay? Some people just get anxious and they don't hear you. So that's why to do it in a couple different ways. By the end, having the patient do the dressing change in front of you, that's a return demonstration, so they know it's teach and it's the do back method. So that's another way that we could have learned through all of this, okay? All right, any questions about wounds? Not when you're all packed up, I know, we're ready to go. Okay. All right, good luck on we'll see you tomorrow.